Hi there and good afternoon. It is Friday, June 12th, 2020. It's 1 o'clock in the afternoon. Want to thank you for joining us. Today you've tuned into the CAF COVID Weekly Roundup. My name is Jason Belton. I'm the Director of Emergency Preparedness with CAF. And while I don't have any fantastic guest speakers this week, we do have some really great folks that are going to join us next week, and I'll get into that a little bit later. And then obviously Courtney Kesterson, the Disaster Preparedness Program Coordinator for CAF, will answer the questions. And then she's got a little PSA. We're going to change how we do the webinars because it takes a while for us to get continuing education for stuff. It takes like 45 days. So when we originally started this, we didn't know how long we were going to do it. Now we figure this may be an ongoing thing, at least for the foreseeable future. Why not get some continuing education credits for folks that tune in? So next week, starting next week, we'll do that. And Courtney's going to give us a little PSA about how to log in and do all that stuff. But we'll get to that towards the end of the webinar today. So I want to thank you again for joining us. It's Friday. Happy Friday, guys. Hopefully your week has been okay. We know that we've gotten a lot of feedback from folks, going through their mitigation plan reviews, and really it's all over the board. We'll get to that. I'll touch on that in a little bit here. So I want to talk to you. Obviously, we normally start these webinars off with talking about what the AFLs are for the week, and of course, I do these. I usually wait until Thursday night to do these slides, so I can capture everything that came in last week. And we didn't really talk about this on last week's webinar, but with the testing, when you get the results from your testing, whether it's baseline testing or the surveillance testing, the baseline testing has a very specific requirement that CDPH wants you to fax in those results. And even though this AFL came out the day before our last webinar, I didn't really cover it. And that on the bottom of that AFL, there is an Excel spreadsheet linked, and that has all the categories that CDPH is looking for. So once you get the completion of your baseline testing and you have those results, you can use that Excel spreadsheet and email it to the address that's listed on the AFL. And of course, I jinxed myself because I said, yep, that's the only one that came out since the last webinar. And then, of course, this morning, a new AFL came out. And so the AFL that came out is not, hopefully it's not hugely impactful for us, but it essentially asked for, CDPH is looking for temporary managers or interim administrators. There's been, obviously, I don't know if you guys have seen this, there was a facility that was evacuated last night in Pasadena, and that's because the Attorney General came in and shut the facility down. Now, we don't know what the reasons were behind that, but we've been told that infection prevention and control is going to become a really serious focus for these folks. And if they see providers that are habitually bad, they're going to use the extreme option to resolve that, rather than kind of the solutions that they've used up to this point. So traditionally, when we've seen providers have struggles or challenges or a particular building, CDPH's last resort is to close that facility down. They really dislike doing that. It's horribly impactful for the residents as well as the staff members, obviously. So they want to avoid that. But based on this AFL, it does not look like they're going to shy away from doing that, and they may take a harder stance on that. So if you've got infection prevention or control problems, the time is now to get those corrected. And if you've had habitual problems, you're going to be an area of focus for those folks. I think we all know that, and I don't want to demean you guys or say this is you at all, but clearly there are some folks that fit within that guideline, and I think CDPH is going to take a more aggressive tact in decertifying those facilities. So obviously they need to have a queue of temporary managers or interim administrators ready to take over those facilities if that happens. So, all right. Enough of the terrible news. Those are terrible news, or that one's terrible. The testing results is very easy. If you read that thing, it should be just very basic information that you're putting in there. And then I wanted to bring up CDC has already released kind of telehealth guidance, but this really expanded on it, and it came out June 9th. And obviously this ties into the waivers, and the waivers allow specifics within within telehealth. And then on that guidance document, as you look at it, it breaks down very, very specifically what types of things qualify for telehealth and how you can accomplish those. How they're billed, things like that. I think it's pretty good a set of guidance, and if you've not already jumped whole cloth into the telehealth thing, or want to kind of explore those options, for foreseeable future until we're out of this, I think this is a good guidance document. If you have questions about it, I know we are Joe Diaz or myself, we can happily walk you through the telehealth stuff. And if you have questions on how it gets built and things like that, Jeff or Jennifer with CAF can also help you out. So if you have questions about that, please send info@caf.org, and we'll direct it to the right person. All right, so many of you guys know this. We've heard the thing from CMS that says for those facilities that have not signed up for NHSN or have not conferred their rights to CDPH, to have CDPH do the weekly polls with CDC. CDC has, or CMS has begun issuing fines. Those fines, the CMP fines, are cited under F884. That's the deficiency. The problem with this is it's not coming in the normal manner in which you would realize you've been cited. So you would have to go to the CASPER system, which is not normally how you receive notification of a deficiency. So you have to go to the CASPER system to be able to see if you were cited for that. And then if that's the case, and you've already gone through the process to sign up and you've conferred your rights, or there was some snag in the process, a technical issue, and you have documented that your attempts to contact them and to get signed up went unanswered, we need that information so that we can give it to CDPH and let them know, hey, listen, you got to advocate for us to CMS and say, you can't find these folks if you fouled up the system and we can't get in, or not CDPH, but CDC. That system is very laborious and extraordinarily difficult for most people to get signed up with if they weren't already. So, but it's very important for you guys to log in there to see if you were fine, especially if you're one of the facilities that had was in that process, and for sure that you had not conferred your rights yet, or that you had even been accepted or got your login ID. So if you fit that criteria, and we know there's probably 200 or 300 facilities that were in that category, go in and look to see, make sure that you didn't get a CMP fine. And then if you were, then contact one of us at CAF, and we'll try to track it down and see what we can do about that. So, but I want to make you aware of that, because you're not going to notice this unless you go to the CASPER system and see it. All right. So I wanted to kind of clarify some things. We've talked to, I'll get to separate types of tests and things like that, but I know we had one question, and I didn't hear it answered on the hospital-associated infections call yesterday, but if we could purchase or get test kits that use this nasal mid-terminate swab or the anterior nasal swabs, both of those can be done through supervised on-site self-collection or home self-collection. The second one could do home self-collection. And the reason why I ask is, you know, I heard them kind of talking about strategies when you have a staff member who may be uncomfortable with the test collection process or anything like that. So when you guys are speaking to labs and you're thinking about getting test kits, or you're ordering test kits, see if that lab provider that you guys are contracting with has the ability to send you those nasal mid-terminate swabs, and so that it may free you up from having to have a nurse do the on-site, do the collection, and you could just supervise the self-collection of your own staff to do that. And that may help them feel more comfortable because they're doing it themselves. They don't have to stick it all the way back up into their nasal cavity. That may help some, but also, I don't know if you've ever had that an MP swab done. It's not super comfortable, and it also presents a problem for the people doing the tests. And so we're in full PPE when we do these tests. Those tests produce droplets, they produce airborne pathogens. If that person's sick, it could potentially cause a risk for the healthcare provider. So I think if you have the opportunity and you could talk to them, and this is allowed by CDC, then maybe that might solve some of those issues. Now, I don't know how many of the labs offer this, but I know that maybe if you're still in the process of trying to find somebody to do this kind of surveillance testing on an ongoing basis, those questions you should ask them. Like, what does the collection look like? Can I use these two type of collection methods? Are those collection methods equivalent? Will I get the same results back versus the other, and things like that. I really think this may help with that, and it may reduce your impact to your operations if you don't have to have an RN actually doing the test. So that should help. And if you want a copy of that, or you want to take a look at the guidelines, you can click on the link below, and that'll take you to all of the stuff on testing, not just what we've talked about here. So, and then I wanted to talk about different kinds of PCR tests, and this came up yesterday. I spoke with well, I won't say the company I spoke with, but somebody is coming up or has a test that's a PCR test, because CDPH was very specific about it being a PCR test, not an antibody test, not an antigen test, not a serology test. It had to be a PCR test. And we had heard in previous calls that it needed to be sent to a needs to be sent to a CLIA approved lab. And when I heard that, I said, well, okay, I don't create any guidance, and CAF doesn't create any guidance. We try to help you guys interpret the guidance that CDPH is given out. And my assumption was that it had to go to a very specific type of lab to be able to get the test results read. Now, this new PCR test that I spoke to a vendor yesterday about promises it to be a PCR test, which is the most important thing because it's the most reliable form of test. But this PCR test is done in your building, meaning you have a piece of equipment that can read the results of the test. Now, it's not as quick as, let's say, the antibody test or some of the other tests that are like 15 minutes, but it does offer the ability to get this test maybe in about get the test results in maybe in about 45 minutes, which is a huge improvement from waiting multiple days. If we could do this with nasal mid-terminate swabs, it would really, really reduce the impact on operations in terms of getting these things done. So, knowing this information, I'm not an expert in lab tests or anything like that. But what I do is I took that information, I sent it to the head of the testing task force. I laid out a case for why we think that this may be an equivalent of the tests that they have, or the labs that they have approved. Can we get permission to use that? And as soon as we get that permission, I'll put it on the forum. Maybe we'll send out an email, because I think this would definitely, now these tests they're not on the shelf, but they're coming. So, but if you see these type of tests offered and it's something that we know we're going to have to do for months and months and months, maybe you're going to want to order one. They're not like sitting around waiting to be bought. Usually, if you want one, you're probably going to have to wait at least 2 or 3 months for them to be manufactured for you to get your actual equipment. But it does offer a marketably simpler process of going through the ongoing surveillance testing, especially if we're doing this every single week on week, year, for a year or something like that. And I wanted to talk about, somebody brought this up from our advisory work group. A lot of folks are doing new hires now. A lot of people, we're trying to bring folks in actively. One of their suggestion was to do virtual interviews rather than have your applicants come to the building, and that you should probably think about testing them before bringing them on site for a visit. And the reason why I say that is this particular facility was hiring new staff. As a condition of employment, they send them to test, and wouldn't you know it, one of the employees came back positive. No symptoms, nothing like that. But that potential new hire had already come into the building, had already been there for an interview. We don't know when they were positive, but it just, when we think about stuff like that, that's probably the last thing from our mind is doing that. So if you've not thought about that and you're in the process of hiring, maybe think about keeping those virtual or outside of the patient care space until you can get them tested. I'm not saying everybody's positive, but there will be enough that maybe it's a thing that you can take a look at. And then I'm sure most of you guys, or a lot of you guys, listen to the hospitals or healthcare associated infection call on Thursdays that CDPH does. They made a complete shift. Normally they have kind of an education session for the first portion, then they respond to questions after that. I think over and over, I've heard this kind of question be asked in a multitude of manners. What's right or what's wrong with staff testing? And the only thing I can make out is there is no right or wrong. Or if there is, CDPH is not going to give us the answer as to what's right or wrong. So, so have a consultation with an employment attorney, see what your rights are as an employer. Make it a condition of employment. I think you can do that. I'm not an attorney, but that seems to be a really consistent message from multiple folks at the state that you could make it a condition of employment. I agree with the assessment that if you're in an outbreak and somebody refuses to get tested, that person should only work with the positives, and they stay home. One of those two. They don't work with anybody that's not a confirmed positive. If they refuse and you have no other cases in your building, well then, maybe it's a matter of having them wear PPE, at all times, or I just don't, the risk is not as great if you know that you have 99.9% of everybody else is negative. So there's still exposure, there's still risk. That's why we want to test everybody. But the risk is much less if you're not in an outbreak. But let's be clear, if you have an outbreak and you have cases in your building and you have somebody refusing to test, treat that person as positive. No question about it, whether it's a staff member or a resident. Look, or if it's a resident, obviously we don't want to put them in with known positives unless they develop symptoms and they refuse to test. But we don't want to put staff that refuse tests when you have outbreaks in with anybody that's not already confirmed positive. That's a no-brainer. Unless they're going to work the positive side, that's fine. They can do that, wear full PPE, all that good stuff. But hopefully, as we explain things to folks, and maybe if we could change the mechanism in which we test these folks, maybe if we can find something that's a self-collection method where they could take it home and test it, or do it with supervision, at least somebody watching them do the test. I think that would be, those are all methods we can get around this. Hopefully these are one-offs, and I don't know what's going through folks' minds. It certainly would be, you know, I would be signed up first to get these tests done. So I don't understand why folks wouldn't want to do it, but I suppose there are, you know, religious and other reasons uh, that I don't understand that may be impactful. So be sympathetic to that, but also understand that if they refuse to get tested, they could represent a risk to the residents in the building. So treat with caution, my friends. All right, and I know this brought up more questions than I answered when folks had questions about this last week. And after doing some research, I've gone back and forth about whether to do this or not, and or whether to recommend this or not. And so I've seen disparate information about what you guys have been recommended to do. And so there's a part of the CDC guidance that really kind of leaves it wide open. They define healthcare personnel or healthcare person, the HCP, as they define that as essentially anybody working in the building. And then they define those other folks that work in the building. It's so open-ended that it really leaves it open to interpretation. And so I cut out this section of what it says about when you should wear face masks and when you should wear, and when it's okay to wear cloth masks. And I'll say that it's not clear, guys. I've tried to read it, and I read that on the CDC website and CDPH. Between the two of them, there's so much gray area in there that I can see a surveyor answering this both ways. And I couldn't argue as to why they would be wrong. That's the problem. And so as I look at this, I think the best practice for us as we think about this, I don't have a personal opinion that says that surgical masks absolutely must be used. I don't know, but I do know that there's protection in those that is different than with a cloth mask. And that's protection for your staff, not necessarily the flow of material out of, you know, it's not exactly air, it's the splashes and sprays that folks are concerned about. Now, whether you choose to use those or not, I'm not making a decision as to whether what's better or what's not, or what's appropriate and where it's appropriate. I think what you're going to have to do is you're going to have to confirm through your mitigation plan review or through your infection prevention survey. You're going to say, what do you want me to do? Because I see two separate things. One says that I can use cloth masks as long as I'm not doing patient care, and one says that pretty much anytime you walk in the building, it's considered patient care. So it's very confusing. What would you prefer me to do? And I think that's probably the only tack that we're going to be able to get, have you make sure that you don't go astray with what the surveyors want. I know those surgical masks are not, there's not great designs on them. You can't make them fashion forward. You know, you can't do creative things with how they look, but definitely they do offer some protection for your staff that's different than a cloth face mask. So when you think about it in those terms. And I don't want to get anybody in trouble. And that's the main thing. I don't want you guys leaving these webinars thinking, oh, cloth mask is fine. I'm going to wear that all the time. And then you get cited the next time a surveyor comes in. It just, I just don't want to get you guys in trouble. So I'd rather have you err on the side of caution until you speak to your surveyor and say, look, where in the building is it okay for me to wear the cloth mask, and where should I use a surgical mask? And then you got to kind of ask yourself, well, is it easier for me to keep that surgical mask on rather than don and doff it and put myself at risk through the doffing process, just to put a cloth mask on, which I'm then going to take off and then put the surgical mask back on? So in terms of operations, it may be easier knowing that at least portions of your work we're going to require the surgical mask. Let's just keep it on for the whole thing, because it presents more risk doing the doffing process and potentially contaminating your hands or gloves or things like that. So that's my suggestion. I realized that was I got like 30 emails about the cloth masks after the last webinar. I don't want to get you guys in trouble, please. We know for sure if you're doing any kind of patient care, whether they're COVID positive or not, they're wearing those surgical masks. But the cloth masks outside of those areas is where we have questions, and I'll just say that it's vague in the guidance as to when you should be switching from cloth to surgical masks. All right. I also heard what I assume is a great piece of information for you guys yesterday on the hospital or the healthcare associated infections. I keep saying hospital. I don't know why I say that, but anyway, the HAI call that is every Thursday, 12 o'clock. Well, one of the main questions, and we post this question to them by email prior to the webinar, was on a 14-day isolation. But they're essentially saying anybody that comes in your mitigation plan, anybody that comes into your facility from an acute or gets transferred in, that person should go into quarantine for 14 days essentially, right? Now they've clarified that. That doesn't mean somebody that you sent out to an acute. That doesn't mean somebody that goes out to dialysis or goes to an ER and then comes back same day, goes to dialysis, goes to an ortho follow-up or whatever it is. If it's an out and back, that doesn't mean they got to be put into a 14-day isolation. Now, obviously, if they're going to, I'd say if they're going to an ER and you're in an area where that ER doesn't have a section set up to deal with COVID and they're throwing everybody in one section, then maybe there's an exposure risk, and certainly you want to pay more attention for symptom development on that person specifically. If you could, if you got all the room in the world, you could put them in a single room if you wanted to. But the reality is those are the exceptions. Very rarely are we going to be able to do that. So I think for the vast majority of folks, after you've done the baseline, you've got a good sense, and that person is already tested negative, and you have no other folks in your facility, then I think the risk is very minor. And I think CDPH agrees with that, and that's why they say the out and back in one day, especially if you already know the status of your whole building, that makes it easier for us to at least have some kind of confidence that that person is not positive. And they don't think that the risk when they go out, depending on where they go out, would be great enough to elevate that to keeping that person in quarantine. Now, they did say any new admit. We know that's pretty much their guidance. That 14 days, we want them separated, and then readmission. Now, like I said, if somebody goes out to an ER visit, maybe ask questions about the hospital. How are they treating COVID? Maybe that hospital, and that most of the hospitals have a dedicated section for people that are, symptomatic, and they're not crossing between the two for the rest of those folks. So we kind of know that most of the time, if they're going to an ER from a sniff, they have very little exposure when they get to the hospital. So it's probably less I'll just say it's less risk than obviously if they had been admitted, but there's still a small amount of risk. But I think the CDPH understands in terms of operationally, as many people, that potentially have to go to an ER and then come back same day, that's going to clog up your operations, and it's going to stop folks from being able to take folks into their building if everybody's on 14-day isolations after they leave. So that's a great news. I know I had received many calls, and that's why we asked that question. And so hopefully that answers it for you guys. If you're still on the fence as to whether, like an ER visit or dialysis or any of those other things are really safe, by all means, if you want to be more conservative, you certainly can. I don't want to stop you from doing that. But I just want you to know that at least, CDPH has said that this is a viable risk at this time. Now, something terrible happens and we start spiking a bunch of cases based on data from folks not being isolated, then obviously things will change. All right. And we're actually going to have, I think, quite a bit of time for questions afterwards, and I always cut you guys short, so I apologize for that. So I just want to talk to you for a few minutes about the video project we're doing. I'm not sure how many of you paid attention to the Senate and Assembly hearings this week that, you know, the legislature is taking a look at, the legislature is taking a look, obviously, at the response in skilled nursing. It's very difficult for us to have you guys, you know, testify down there because you're working in the buildings in which they all talk about. But for those of us that kind of worked around the Capitol, and we knew Craig was going to go testify, and we knew Heidi Steinecker was going to testify in front of the legislature, we talked. But outside of a few kind of level-headed folks, we know that legislative process is full of voices from folks that really have a bone to pick with skilled nursing as a profession, and but also as an industry. And so we had originally talked about doing a video project and creating some kind of media campaign built around best, you know, stories and best practices that providers are doing. I mean, it's clear that, you know, and this has always been the case, but it's even magnified now, is us in skilled nursing facilities that work in skilled nursing facilities are often defined by the minimum. So we're defined by providers that are not as good as other providers. And I don't care what industry you work in, I don't care who you are, there's going to be folks that are great at their job and there's going to be folks that aren't very good at their job. And that's magnified when we take care of people's health. And so what happens is these folks, you know, look at the 10% and they go, that's the definition of all 100%, and that applies broadly. And it's the rush to judgment and the just kind of black and white nature of how we deal with things. So how do we address that? And how, because our concern about the long-term viability of you guys' business is real. And so how do we get the story out that is absolutely the wrong message? It's the wrong thing. That's not what's indicative of what happens in skilled nursing, not on any day. And it really frustrates me, but it also motivates me and makes me want to think about things that we can do to make a difference. And we've talked many times about being partners with each other and you know, and things like that. But we're going to kind of transition maybe this video project, or at least take some of the video that we're using, and we're going to build it around certain categories of what happened within the COVID response, both within what our actions were, what are fantastic things that we did to you know, reduce anxiety in our staff, or how did we help our residents overcome the isolation of not being able to see their family members. All of those great stories that are drowned out by poor stories in the media, and they're echoed in the legislature. We need to take that information and we need to give it directly to the legislators. And if we can't go testify at the legislature because we're actually busy doing work protecting people's lives during the pandemic, then we need to give them something so that they don't ever have to leave to see our story. And so what we want to do is we want to create video projects, and we want to be able to give those to the legislators and the senators in those areas so that they can see what their constituents went through, what they do every day, and how they care about their residents. I think it's extraordinarily important, guys. I really do. I think this could be impactful. Not to mention, you know, there's a ton of conversations about changing skilled nursing care and things like that. And while I don't disagree that we would love some help on the long-term medically indigent folks that stay in our building for years and years and years, uh, those folks, maybe there is an option for them, but skilled nursing care is extraordinarily valuable. And as our society ages, we're going to need those beds, and we're going to need um, capable, quality folks working in those buildings. And if we chase them all off, there's not going to be anybody here to left to take care of them. So anyways, what we plan to do, it's not a news interview. It's going to be me or Courtney interviewing you or your staff, but we need volunteers, guys. Real, like, seriously. I don't even care if you're leadership or if you're a line staff. It does not matter. I need stories, good stories. I need facts. I need data about what your experience was, and I need to capture it on camera. And that is going to be impactful, guys. We've already recorded a few of these. We've got a few more coming this afternoon and some more next week we're going to do. But I really do. I think if we can't rattle their cage enough, then we need to bring them the story to them. Because I don't think it's appropriate to have others tell your story, and folks without any experience working in buildings are telling those stories. They're the ones that are getting up and testifying in front of the legislature, and you go, well, you have no actual experience, you have no stake in the game, nothing invested. So we need to be able to tell that story. And then I don't know if you've heard this, but AHCA is going to, which is our national organization, is going to create a media campaign that's going to address some of those issues as well. You know, we're drowned out in the media, so we need to kind of address that nationally as well with the decision makers in DC. So the national media campaign came as an assessment. Obviously, if you guys are administrators of buildings, you might, it's not a huge amount of money that they're going to assess to each facility. I think it's $10 a bed. It's meant to create a $15 million pot of money that they can use to do a media campaign all over the country, but specific, very targeted markets and things like that, especially around DC. And so you'll see those national media campaigns, especially I think in some of the larger markets, Los Angeles and the Bay Area. You may see some media campaigns as well from the American Healthcare Association. All right. And so what do we see in the coming weeks? We know that there are a number of waivers that are set to expire at the end of June. We have, CDPH has asked us feedback as to what we think operationally, what providers still need. And then we're going to send them kind of a list of things. But I think we anticipate, we know AFL 20-22.2, that's the one that restricts visitation, ends June 30th. It was extended from June 1 to June 30th last week. And but we do think at a bare minimum that's going to be modified, because I think visitation is a really big concern for folks. And we talked about the visitation guidance. You know, I didn't put a link here, but if you go to the caf.org/coronavirus and scroll down to the CAF guidance documents, there is the visitation guidance that Deanne is the head of a work group that all work to put that together, but primarily it's Deanne's work mostly. And Deanne put that together. It's on the website now, and that will walk you through kind of the guidelines for resuming visitation. But we think that's probably, it's either going to be modified to talk about more types of visitation that's allowed, or it will be removed altogether. But I suspect that will be changed very, very soon. And there's a lot of family members, a lot of advocates, really ombudsman. Everybody wants to get back into the building. So, and with that, I'll just say that we had asked, since all of our staff, including ancillary staff or staff that don't do direct patient care, all of those folks are required to get tested. What will be the requirement of ancillary staff or contract staff or surveyors or anybody else that's going to want to come into the building, ombudsman? We're testing all of our staff because that That's an exposure risk. What is the testing going to look like for all these other folks? And so is it going to be they're wearing full PPE? Is it, I don't know what it's going to look like, but those are the questions we're asking a CDPH before they start talking about, getting all these folks in the building. And our question specifically was, survey of staff are going from building to building. It's silly to me that those folks aren't tested. They present an even bigger risk to the residents than the staff that are in the building because they're going from building to building. And so I realize they're not giving direct patient care, but there's a lot of people in our folks that don't do direct patient care. So we've been asking them like, hey, okay, you want us to test? Maybe the other folks that present risk should also be tested. So we asked that about as we resume visitation, as we resume services back in our building, what are we going to require of those contract staff that come into our building? Are we going to require a test? Are we going to require them to do their work in a specific area? Is that area going to be set up with negative pressure? I don't know what it looks like, but we anticipate that's coming. And as you think about this, I think this is probably June 30th is when your target date to have all this stuff planned out and ready to go. There obviously will be counties where this will not be changed. And I'm thinking specifically Los Angeles, and maybe some of the counties that were more impacted may not remove their own restriction on visitation. So it's, it kind of, CMS sets the baseline, CDPH adds their flavor to it, and then the local health department has the ultimate authority. So, if the local health department has said, no, you can't open up for visitation after June 30th, you've got to do what the local health department says. They've got the final authority. Now, if they say you can open up, but the state says no, then the state has kind of within their AFL gave you some gray area to work with the local health department and develop a creative solution to that. And especially if you're looking at doing visitation outside under a canopy, you're coordinating that with appointments, you're only doing a couple a day, you're cleaning between things, all of those things. I know some folks are doing that. That I believe is allowed now, and you can take that guidance document that's on the CAF website and you can develop your plan to start that right now. So, and I wanted to mention care coordination because the folks from the Hospital Association are still having issues discharging COVID positive folks. And I said, well, yeah, that's, I don't anticipate that's going to go away. But if you have relationships with hospitals or you're a facility that has dedicated space to taking care of those folks, I know the hospitals don't know where those beds exist. So maybe talk to the folks in your county and say, look, I have this space, I'm ready to take these folks. You can coordinate the movement between the hospitals and me. I know not everybody's comfortable with that, and I'm not going to say what you get to do in your business. That's your own. It's your own decision to do that. Continued media attention is happening. What we're noticing now is we've seen a number of reporters, local news reporters, wait outside of nursing homes to query or question staff as they leave the facility. Obviously, it's really common after an outbreak's been identified, but even in facilities where we've not had outbreaks, we've seen this happen. And what the main thing they're looking for is they're these kind of leading questions where they're asking, like, how do you feel about the personal protective equipment you were assigned? Was it enough? And maybe we've done a poor job of telling our staff what the PPE is, when they'll be assigned to it, when they'll be issued it, and when they're supposed to wear it. And I think if we have that kind of transparency, and we have a conversation with them, even if you had a written documentation or something from CDC that shows this is when you wear what, we're going to provide everything that the CDC recommends during the time that you're at risk here, and this is when you're going to have to wear it. So if they understand that when they go out, you know, like, do I want to be assigned one N95 for the entire day? No, but that's the only thing that I have now. I can't give you one for every use. I just can't do it. I mean, it's a massively different amount of PPE that we just don't have. And so, you know, be cognizant of that the media is looking at folks, even if you don't have an outbreak, and talking to your staff when they leave the building. Let your staff know what PPE is. Let them know you're following the CDC guidelines every second of the day while they're at work. We're protecting you. This is everything that I could do to make you as safe as possible. And I think if we give them that information and then encourage them to reach out to leadership if they're contacted by the media so that we can address the media, and then talk to Deb Pacina if you have issues or you need some help creating media messaging after you've already been identified or targeted in your local media. And just want a quick second to say, I want drop this on your plate one more time, guys. I need you guys to all review your shelter-in-place plans. As we move into wildfire season, I know it's terrible to think that we could have a natural disaster at the same time as a pandemic, but it does happen, it has happened, and it probably will happen again this summer. So take a look at your shelter-in-place plans and your surge plans to see, well, gosh, if I get a call from my county saying, how many beds do I have? I got a facility evacuating and I need to put folks in your building. You need to think about what questions you ask before that happens. Obviously, the first one is that person COVID positive. Second one is, when's the last time that person's been tested? What's been their exposure since they've left? Did they go to were they staged in a you know, in a staging area right next to other folks in a confined space? I don't know, but those are all questions you should think about asking prior when you do your search plan. And then I mentioned next week the attorneys, we mentioned we were going to have some guest speakers next week. They're going to deal specifically with Cal OSHA, and these are going to be two attorneys that specialize in Cal OSHA workplace stuff, workplace safety, and specifically within healthcare. I listened to a webinar that they put on a couple of weeks ago. They were fantastic, answered a ton of questions that I'd had about our folks, and I think you guys will get a lot from that. So not to mention you get an hour CE if you log in. So I want to jump to questions. Courtney, do you have, can you give us a kind of a breakdown of what people need to do next week to sign in and get logged in for the webinar?
Hi there, yes. Can you hear me okay?
I sure can, yeah.
Okay. So I'd like to draw everyone's attention really quickly to the handout section for today. There's going to be a document on there that has the links and call-in numbers for the rest of the webinars until the end of July. So next week, we're going to start offering an hour of CEs for these webinars. And the way that registration is going to be set up, there's a new link per week. And if anyone has any trouble with the links, please contact me. And then the CE evaluations will be on CAF.org. So if you're not a member, you will need to make a free CAF account in order to access that. And then your certificate should be available right away or within 24 hours on CAF.org. And that's all I have to say about that. And
you want to jump into
we
questions?
can go ahead and, yeah, move into questions. Okay. So I see one question on here regarding the provider stories. What's the deadline or time frame? I can go ahead and answer that as soon as possible. If you are interested, go ahead and reach out to me or Jason, and we'll get you scheduled. Because one thing that we'd also like to do, I don't know if Jason elaborated on this, but we want to get these stories and get them to your local legislators as well, and then put these on YouTube. So we have a consent release form, and if you want to do the interview anonymously, we have an option to do that. We'll disguise your, we'll make it all true crime looking and disguise your voice and stuff, whatever you're comfortable doing. And if anyone has any further questions about that, you can shoot me an email, and then I will get into the questions regarding Jason's presentation right now. Okay, so first question here, are we required to have consent forms signed by the residents for testing, or will MD orders suffice, assuming we need MD orders since other states don't require this when testing is done by a state lab?
Yeah, we asked them that question if they needed orders to get the test, and as of yet, they've said no. Um, so as for the consent form, I don't know. That's a good question. I know somebody asked yesterday about having the staff sign a consent form. I think what I want to do is I posed the question to our general counsel. I'll ask him again. I think that's probably something that an attorney needs to answer in terms of the consent form for the staff. Um, I don't know about the residents, but I will ask. That's a great question. I hate to deflect because I know other folks that do webinars that do that. I'm not going to mention who, but uh, I realize that. I just don't have an answer, and if I did, I would give it to you. But I will find the answer, and I will put it on the forum, and I will address it in the webinar next week. Thank you.
Okay, next question. Our dialysis residents are being placed on quarantine based on the recommendation of the local licensing office during the survey. None of them are showing symptoms at all. Should we continue with their quarantine? It burns our PPE, and on top of that, we confirmed the local dialysis clinic has a separate location for positive cases.
Yeah, I mean, that's the perfect scenario of why you should not, why it's a minimal risk for a ton of burn of PPE and operational, kind of headaches. It's absolutely. Now the one caveat is that those those surveyors that are in your building really, if they say that, we need to kind of address that with the district office. So if it's a CDPH surveyor that says that, this is CDPH that told us that was appropriate. So we can address that with the district office. Now, if it's the local health department, meaning somebody from county health department, or a city health department, depending on where you are, if it's from them, they can create their own guidance that's stricter than CDPH. And if they need to produce that in a written document, and that has to be written. If it's not written, then that's their own description of how that should play out. But they have the ultimate authority. So if it's the county health department, then you've kind of got to do what they say. But if it's the CDPH office, let us know what district office that is, and we can address it with the district office. And we can say, here's the clarification we got from headquarters. Can you please pass this along to the surveyors out in the field? All right, next question.
Is it really required for a SNF to have one dedicated infection preventionist in the building?
Yes. Simple, easy question. Well, at least according to the AFL, absolutely. And not only that, most of the reviews I'm seeing of the mitigation plan, they want very specific information about how many hours, when those hours will be spent, what's the name of the person. If you have multiple staff members, that is the number one goal of that mitigation plan, was to have some infection prevention champion or whatever you want to call it. Your leader of infection prevention at each facility. I've heard that on multiple occasions, and I know for certain that they expect to have 40 hours of work dedicated infection preventionists. All right, next question.
Can CAF reach out to the head of CDPH regarding surgical masks versus cloth masks so the correct information can be passed down to surveyors?
Yeah, no, I know there is a difference. I mean, I can see that there's a difference. I know why the surveyors kind of, go back and forth. If you've got enough surgical masks where you can burn them every time, you're just chucking them every time. If you got thousands of those things, then maybe it's easier to go from a surgical mask to a cloth mask back to a surgical mask. But if you're not at the point where you can just toss them away after each use, then it's probably not even smart to go back and forth. But I will say that if, I just think there's been enough gray area that I could see that they could do that. But we have asked them if they could clarify when cloth masks were going to be allowed. I asked them that actually a couple of weeks ago, and I asked them that twice now, and I've not gotten a response. And I think they feel like it's clearly defined enough, but I'll keep following up. I will. I don't know that we're going to get a great answer from them on this specific thing. So, all right, next question.
It's for the baseline testing AFL. It says this is required for sites who do not have any positive cases. We are interpreting this to mean we do not need to report if we had positive cases that began in April and do not have a single baseline test for everyone. Is that correct?
I'm sorry, can you read that one more time? It was very detailed. Can you read it one more time?
For sure. For the baseline testing AFL, it says this is required for sites who do not have any positive cases. We are interpreting this to mean we do not need to report if we have positive cases that began in April and do not have a single baseline test for everyone. Is that correct?
I don't think so. I think they want, it just says when a facility completes their baseline testing, they must report to the following to the respective district office. Now, they've said that the baseline testing could be accepted from either June or May. They did not say it could go back to April. So I think that might be a situation where we would have to advocate for your specific facility rather than ask them a broad question. I don't know if they'll accept that you did that test in April, but I do know that they're pretty clear. They want something from each facility saying, once you complete your baseline testing, fill out that Excel spreadsheet and send it in. Whether you have cases or not, it's fine. But the fact that you did your testing in April, I think may mean you have to do it again. But I'd be happy to advocate on your behalf, especially if 90% of your residents are the same and nobody spiked any cases or anything like that. So we could definitely advocate. So send your name and email address to info@caf.org to my attention. Let me know where your facility is located and we'll find the district office when we can talk to them. So, all right, next question.
Is there a website or someplace I can get a list of legitimate mobile testing companies?
The testing, it's testing. Here, I'll give you the exact address. Give me 1 second here. As I start typing in, it'll come up. All right, testing.covid19.ca.gov / So if you go to that link on the bottom, there should be a section that says lab COVID-19 lab resources, and if you expand that link, the very bottom is a PDF download of testing labs. Some of those labs have a mobile service. What you want to look is for the ones that are in the full service category, and that would mean where they would come to you to do the tests and do the whole process internally within one thing. And then they got a couple other categories where they'll mail you the kits and things like that. That PCR test that I mentioned earlier would not require you to send stuff out. You would have the equipment right there. So obviously that would mean you'd have to purchase the equipment, but it may make it a lot easier to do that than this. Okay, next question.
Jason,
yeah.
Jason, could you read that URL one more time so I can type it into the answer box for everyone?
Oh, sure. It's testing.covid19.ca.gov.
Okay, great. And one more question I see on here before we wrap up. Who is going to pay for tests? We do not have the resources for that.
Yeah, and the Department of Managed Healthcare Services has sent out a FAQ that basically said that all health insurance, every health insurance plan in America needs to cover COVID testing, whether you have symptoms or not, whether you have an order from a doctor or not. And so that's applies to everybody in the state, whether you work for a skilled nursing facility or not. That applies to everybody. So for us, if you're contracting with one of those full service lab companies, they're the ones that are doing the billing. Now, we realize that not everybody has health insurance. We know everybody's supposed to have health insurance, but not everybody does have health insurance. And or somebody might be on their spouse's plan, or they may not work often enough, and maybe they're part-time and they don't have health care at all. You know, there are a lot of issues with that. We realize that it's not a perfect system, but you know, I think some of those things are going to fall back on the providers, especially if you have somebody that has no health insurance at all. We do know that Covered California increased their open enrollment period. So if you have folks that are not, that don't have health insurance, they can now get signed up. I can't remember when that expires, but at least at the moment, for right now, as of today, they can go in and get signed up. You know, I don't know how long they're going to extend that. But if you have folks that don't have health insurance, they can get signed up, and that way their tests can be paid for. Otherwise, you're going to be the one probably paying for any uninsured employees. So hopefully that helped answer your question. That FAQ is listed, I believe, on the CAF website, on the coronavirus website, and that just basically, you know, that we've been providing that to health plans, like, hey, this says you guys are responsible for paying this, and knock on wood, I have not seen haven't seen any blowback from the labs yet. But as soon as you guys get a huge bill from a lab saying, you know what, I sent it to the health plan and they didn't send me any money, so now I'm sending you the bill. You know, as soon as you see that, reach out to CAF and let us know, because we'll go, hey, wait, something's broken in this process, and we got to get it figured out. So, all right, guys, thanks for your time. I really appreciate it. You guys have a wonderful weekend, and please join us next week. We'll have free CEs for you guys, as well as two wonderful attorneys talking about something that we hope never happens to us. So we hope you have a great weekend. Thanks very much. Bye-bye.